Thank you so much, dear Ramesh, Ja- from Jardian's division of Boringer Ingelham, for your kind introduction. And very good evening, my dear professional colleagues. And I'm thankful to Boringer Ingelham for giving me this opportunity to be the speaker of this evening. So, I am Dr.Sepuri Mohan. I am an endocrinologist at my own center, Sepuri Diabetes and Endocrine Center, Karnool. So today we are going to talk about the molecule, the empagliflozin, the original research molecule of Boehringer Ingelheim, the brand name being the Jardiance, which is available with the same name all over the world. So this is the one that is not off patented yet. It has got patent rights until 2025 actually. So I'll give you a brief introduction about what we are going to talk about today. So it is the broadly we call it the Jardiance meat actually. So we are going to talk about the SGLT2 inhibitors, the class of drugs, the latest class of drugs which act through the kidneys actually. So these drugs they act by inhibiting the SGLT2 inhibitors which are present in the proximal convoluted tubules of the glomerulus apparatus of the kidney, the juxtaglomerular apparatus. So there are SGLT1 receptors also which are present in the proximal straight tubule, that is we call the SGLT2, they are in the PCT, that is the proximal convoluted tubule, whereas the SGLT1 inhibitors are present in the proximal straight tubule, that is PST. Basically we are concerned with the SGLT2 inhibition, which is that is going to have the dramatic effect in lowering the glucose. So there is all other molecules in this class, the SGLT2 inhibitors are called the gliflozins actually. Like we call gliptins, the DPP4 inhibitors we call gliptins. Likewise, we call this SGLT2 inhibitor class of drugs the gliflozins. See, there are quite few number of the gliflozins, that is SGLT2 inhibitors, which are approved by the United States of Food and Drug Administration, USFDA. The first one being canagliflozin, which was given approval in the month of October 17th, 2013, and followed by the empagliflozin in the early months of 2014, and followed by dapagliflozin in the late months of the 2014 actually. So these three molecules which are approved by USFDA are available in India actually. The first is canagliflozin, followed by empagliflozin. Canagliflozin is from Johnson and Johnson, and the empagliflozin is an original research product of Boehringer Ingelheim, and the dapagliflozin is from the AstraZeneca. The brand name is Foxiga actually, and for that particular canagliflozin, the brand name is Invokana. Invokana is available in the dose of 100 and 300, whereas the empagliflozin is available in the dose of 10 and 25, dapagliflozin in the dose of 5 and 10 respectively. But all the trials done with this particular the gliflozins, the three gliflozins, the first one is the canagliflozin. The cardiovascular outcome trial is called the CANVAS, and the CANVAS R followed by the CANVAS are ongoing. So there are number of trials as far as the empagliflozin are concerned. So it started with the EMPA-REG, and then by EMPA-REG outcomes, and then several like Emperor HF, and the EMPA kidney, and the EMPA HF. Several trials are done. EMPRISE is one. So the molecule empagliflozin is backed up by so much of evidence-based medicine, and so many cardiovascular outcome trials it has got. And the dapagliflozin, of course, to start with, they declare TIMI 58, and followed by the DAPA HF, and followed by the DAPA CKD. These are all the trials, the cardiovascular outcome trials, as far as the molecules which are available in India. So, the molecules which are approved by US FDA, which are not available in India, are the ertugliflozin and the sotagliflozin. The speciality of sotagliflozin is this is the only one molecule in the basket of the SGLT2 inhibitors, which has got a unique mechanism of action by inhibiting the SGLT2 1 receptors as well as the SGLT2 receptors. So this is the only one molecule. The take-home message is sotagliflozin actually, and these are not available. The pragliflozin is there, and there are several gliflozins in the pipeline actually. So they are yet to come, yet to have the approval of US FDA. So this is the basic introduction. See, they act by the inhibiting the SGLT2 inhibitors. As I said, the empagliflozin acts by like inhibiting the SGLT2 inhibitor, which is present in the proximal convoluted tubule in the juxtaglomerular apparatus, and it inhibits the reabsorption of glucose by the kidneys. So thereby it facilitates the excretion of glucose from the body. On average, all the gliflozins, they vary from 1 to 1 as far as the quantity of glucose that is being excreted in a day, that is the given period 24 hours. Around 60 to 120 grams of glucose is excreted through the urine. So that is the reason you find the weight reduction in this class of drugs. The basket of gliflozins, they find we find this particular apart from the mechanism of action, what I said, by inhibiting the SGLT2 inhibitors and blocking the reabsorption of glucose by the kidneys, and excretion of this particular glucose through urine. So you take empagliflozin, on an average around 80 to 100 grams of glucose is excreted in the given 24 hours. So whenever the patient is on gliflozins, there are several conditions where you find the blood sugars normal, and the 1 plus, 2 plus, 3 plus, or 4 plus when you do the urine examination for glucose actually. So the one condition is the rare condition is renal glycosuria, wherein the blood sugars will be normal. Only the urine excretes the blood sugar, blood glucose. You find 1 plus or 2 plus or 3 plus. I've got 3 patients as of now who have this particular the rare problem. I said the renal glycosuria. They don't require any sort of treatment, they just require the follow-up. The reason for weight reduction is the excretion of glucose. So when you find this particular patients who are on SGLT2 inhibitors, the blood glucose will be somewhere around, the fasting will be 100 and post lunch will be 140, 150. But still, the urine may show 1 plus or 2 plus or 3 plus. Don't get worried about it, don't get perplexed. The mechanism I have told, that is, the glucose is excreted by the kidneys in those patients who are on the subset of the basket of glyphosins. That is the reason you find the presence of glucose depending upon the glyphosin you use. So one more thing I would like to touch upon is there are some debatable issues as far as this particular SGLT2 are concerned. The first being whether all these effects are the class effect or the drug effect. See, when we take the 3-point MACE, so it is almost, we thought until the etogliflozin, that is the what is CV study showed a very disappointing results as far as 3-point MACE outcomes were concerned. We thought the protection in reducing the incidence of 3-point MACE was a class effect, like canagliflozin, empagliflozin, dapagliflozin. All glyphosins will exert the same mechanism of action and same outcomes. But we had some when what is CV were rolled out in the ADA. See, we had some disappointing results, whereas the what is CV failed to show the statistically significant clinical outcomes, the cardiovascular clinical outcomes are concerned. But when you take this particularly the heart failure and the hospitalization for heart failure, see, even what is CV, the etogliflozin molecule also exerted the same benefits, that is with regards to the reduction in the heart failure, the reduction of incidence in the hospitalization for heart failure, which we call HF and HF. So this is one point where we need to debate actually, whether it's a class effect or the drug effect. And second thing was raised when canagliflozin, the canvas R actually showed the increased incidence of the risk of fractures and the increased incidence of risk of lower limb extremity amputations. We call it LLEA. The group of patients who were on this canagliflozin had shown this particular the increased incidence for the fractures as well as the lower limb extremity amputations, whereas the other the empagliflozin and dapagliflozin did not show this particular the side effects or the adverse effects. Especially the lower limb extremity amputations were confined to the grade 2. Per se, the grade 2 was that was involved actually, and ankle amputation and all, and below knee amputation was seen in the patients who are on glyphosins. So we get a doubt whether this particular is unique to canagliflozin or unique to the other things, because the evidence medicine says the canagliflozin group only showed this the two main side effects, the adverse effects events, whereas the others did not exert this particular adverse events. So these two things, the what is CV as well as the canvas and canvas are showing these differences. The particularly it rises to a question mark in the everybody's mind, whether these effects are class effect or drug effect. And evidence medicine clearly shows, the evidence-based medicine very clearly shows that it is not the class effect but the drug effect. And later on, when credence rolled out, very surprisingly, nothing change happened as far as canagliflozin is concerned. That is the credence is the study, the benefits on the kidney. So all of a sudden they declared there is no increased risk in the risk of fractures. There is no increased risk in the amputations of the grade 2 as well as the half foot amputation or the below knee amputation. That is, it was at par with empagliflozin and dapagliflozin when we did not find any increased incidence of this particular the fractures and the lower limb extremity amputations. So, with this a brief introduction and one more thing, see, these drugs are strictly for the usage of the type 2 only. The patients suffering from type 2 only, we use this particular the gliflozins or the SGLT2 inhibitors. That is the main indication as approved by US FDA. But in the European Union, the off-label indication, like they started using this particular empagliflozin and dapagliflozin and sotagliflozin even in type 1 diabetes patients actually. So what they observed is the requirement of daily dose of insulin has come down drastically after introducing empagliflozin to this type 1 diabetes patients, but also they noticed some sort of dehydration and some incidents of euglycemic DKA, which is very life threatening. So as of now, as far as Indian continent is concerned, even the US FDA or our Indian FDA has given us the approval to be these particular gliflozins to be used in the patients suffering from type 2 diabetes mellitus. To complete that, I said that European Union started using it and still using it with utmost cautious they are using. So the seeing to that extent that the T1DM patients, they don't get into the dehydration or the by giving adequate hydration or the preventing the euglycemic DKA. But the inference is there is the significant drop in the daily dose of insulins as far as these are used in type 1 diabetes mellitus. So with this brief introduction, I think we'll get into the Jardian's molecule in depth. And so today the given topic is the cardiovascular protection across the cardiovascular, renal and metabolic conditions using the SGLT2 inhibitors, that is the sodium glucose co-transporters 2 inhibitors. An evidence-based approach by reducing the risk for people with type 2 diabetes mellitus. So, when the molecules emerged, see, we have been following these molecules even before, 5 to 6 years prior to the US FDA gave approval in all the American Diabetes Association scientific sessions and the EASD scientific sessions, that is European study for the European Association for the Study of Diabetes, the scientific sessions, the ACE scientific sessions, that is the American College of Endocrinology, and the AACE scientific sessions, which are held only in US. ADA, AS and AACE are confined only to this particular the America, the Northern America, that is the America which has got the 50 states. So the American College of Endocrinology and the American Association for the Clinical Endocrinologists and the American Diabetes Association, they were discussing in length regarding this about this SGLT2 inhibitors when they were in the trial phase, actually phase 1 clinical trials, phase 2, phase 3 and all. So these drugs emerged as the glucose lowering effects, the glucose lowering drugs per se. And later on, the studies have shown that they have a very good effect with regards to the systolic blood pressure to a tune of 8 to 12 millimeters of mercury drop in the systolic blood pressure, and 2 to 4 millimeter per mercury drop of diastolic blood pressure, which was very statistically significant, and that was very much useful in the reductions in the incidence of nocturnal hypertension, one, and the second is the resistant hypertension, along with the standard the treatment for this particular the resistant hypertension and the nocturnal hypertension. So, you know the definition of resistant hypertension. Even the patient is on 3 drugs, one drug being exclusively a diuretic, a thiazide diuretic or thiazide-like diuretic. When the patient doesn't get back to the target, the goal of 120 to 130 systolic blood pressure and 80 of diastolic blood pressure, with all the precautions, like when the patient is not sick, not running any infection, no temperature, patient is stable and is adherent to diet, exercise, and the DASH diet and weight reduction, cessation of smoking, cessation of alcohol, using the drugs very thoroughly given by the physician, clinician, or the diabetologist, or the endocrinologist, or the hypertension specialist, the cardiologist, or the nephrologist. Still, they don't reach to the normalcy. That is called resistant hypertension. And most of the times, what we see in our clinical practice is not the true resistant hypertension, it is pseudo resistant hypertension, wherein the patient says that he is using the medicines, but he is not using the medicines. And the nocturnal hypertension is the daytime they are okay, but nighttime the danger hours are between 2 a.m. to 4 a.m., where there is a lot of the catecholamine surge, the counter regulatory hormone surge, which are otherwise known as the stress hormones actually. So, whenever there is the increased surge in the stress hormones or the counter regulatory hormones, which are 6 in number, that is the glucagon and the thyroid hormone and the adrenaline, noradrenaline, and the thyroid hormone and the growth hormone. Whenever there is increased surge during that period, automatically the insulin secretion is suppressed. Thereby, the rise in the blood pressure and the blood sugar, that particularly results in the increased incidence of heart attacks and the paralysis. That is called the danger bells, danger hour bells. See, most of the ERs, the emergency rooms, they get the cases of this particular the coronary artery disease or the heart attacks or the strokes during this the precious hours, the early in the morning, where the mechanism I have explained already. So they emerged as the glucose lowering drugs. Later on, they exerted a very good effect in reducing the blood pressure, thereby helping the resistant hypertension as well as the nocturnal hypertension, along with the standard treatment for this particular resistant and nocturnal hypertension. And later on, we found that the weight reduced significantly. The reason I have told, the excretion of glucose from the urine, as these drugs inhibit the reabsorption of glucose by the juxtaglomerular apparatus. So that is the reason. And later on, we thought that it is endocrine domain or the clinician's domain or the physician's domain or the, the diabetologist domain actually. So later on, the study showed the favorable effects on the heart actually with regards to 3-point MACE and the heart failure and the incidence of hospitalization for heart failure. So then cardiologists thought it is our molecule. And then when it exerted after the EMPA kidney or the credence of with clanagliflozin, the EMPA kidney, that is with empagliflozin and DAPA CKD, that is with the dapagliflozin, that exerted the beautiful results in the decreased the incidence of the chronic kidney disease or the diabetic kidney disease, with showing the improvements in the estimated glomerular filtration rate. Then everybody thought it is nephrologist product also. So when it exerted a very favorable effect in the stage of NAFLD and NASH, which are now termed as MAFLD and MASH. So the favorable outcomes in the chronic liver disease, even the beginning of the liver disease, the NAFLD and the NASH, and the latter stages. Okay, there are 4 stages. First is NAFLD, and they are the MAFLD, and second is NASH or the MASH, and third is the cirrhosis, and fourth is hepatocellular carcinoma. Nothing to do with hepatocellular carcinoma. Even as far as the scarring is concerned, the fibrosis is concerned, that is cirrhosis also, all the drugs have a minimal role to play with. But if you catch up them in the stage of the first stage, when the ultrasound the abdomen, the radiologist gives this particular the fatty liver, grade 1 or grade 2 or grade 3. When they send the patient for gastroenterologist consultation with a fibroelastogram, they measure the degree of the problem, whether it is in the stage 1 or stage 2, and with that we can treat that, and it has got a favorable effect on that also. So then medical gastroenterologists started claiming that it's their product. So this is totally in general what we call, apart from the main effect exerting so many additional benefits, we call it pleiotropism. So like the insulin, like metformin, like statins, SGLT2 inhibitors are the best pleiotropic drugs of this particular this decades, 2-3 decades. I think in the future also, to the best of my knowledge, we don't get any better drug when compared to SGLT2 inhibitors, if it is tolerated and if it is given to the right candidate in the right dosage actually. All the trials of empagliflozin are done with only 25 milligram, not with 10 milligram, canagliflozin with 300 milligram, and the dapagliflozin with 10 milligram, and the atugliflozin with only 5 milligram. That is the dose with which we have done, we have seen the trials being done, the cardiovascular outcome trials being done. So with this, we move on to an evidence-based approach by reducing the risk for people with type 2 diabetes mellitus with our empagliflozin actually. So per se, see, what is the definition of cardiovascular, renal and metabolic disease? So the question itself is self-explanatory. So the definition is nothing but the beneficial effects on the cardiovascular system and the kidneys and the metabolic, that is, or diabetes. So the Journal of Diabetes and its Complications says the DCRM multi-speciality practice recommendations for the management of diabetes and cardiorenal and metabolic diseases. This is okay, and followed by the Circulation, which is a world famous journal, and the American Heart Association Presidential Advisory said cardiovascular, kidney, metabolic health, a presidential advisory from the American Heart Association. So on the right hand side, you see the systemic disorder characterized by pathophysiological interactions among the metabolic risk factors, that is obesity, diabetes, and the chronic kidney disease, and the cardiovascular systems, that is heart failure, the atrial fibrillation, the coronary heart disease and stroke, and the peripheral artery disease and the peripheral vascular disease. These overlapping etiologies lead to multi-organ dysfunction and a high rate of adverse cardiovascular outcomes. This includes the individuals at risk of cardiovascular disease due to the presence of the metabolic risk factors, the CKD, or both, and individuals with existing cardiovascular disease that is potentially related to or the complicates the metabolic risk factors or CKD. So this is the definition of the cardiovascular, renal and metabolic disease actually. And this slide shows on the left hand side the cardiorenal metabolic diseases. The interconnectivity between these cardiometabolic and the renal diseases is increasingly well recognized, and the approach of treatment is becoming more holistic actually. See, we cannot differentiate the type 2 diabetes from heart problems, and the heart problems from the kidney problems, because they are all interrelated, they are all overlapped actually. So you see the in the middle you find the cardiorenal metabolic diseases, and you find the multiple factors, the lifestyle factors on the right hand side, and the classical treatments and the new treatments. So you find the triad of the renal, which leads to the CKD, and the cardiovascular that leads to the heart failure, and the metabolic that leads to the type 2 diabetes, followed by the obesity. And lifestyle modifications, okay, you know that, okay, the physical activity and the diet and the loss of weight, and the cessation of smoking and cessation of alcohol. These five constitute the therapeutic lifestyle changes or the lifestyle modifications. And the classical treatments, that is, it's not sufficient if you treat only diabetes. It doesn't mean that only you can control blood pressure and you expect some dramatic relief. So this is interrelated. Once you keep thinking about, all the time have it in your mind, the term ABC. A stands for A1C, that is the control of blood sugar. B stands for blood pressure, that is control of meticulous control of blood pressure. C stands for cholesterol. All the time you remember all these things. The lipid management and the glycemic control and the blood pressure reduction and the RAS blockade. And the new treatments are again the SGLT2 inhibitors and the GLP1 receptor agonists as far as type 2 diabetes is concerned, and in the treatment of obesity, the GLP1 receptor agonists have got a tremendous role to play. That is, that started with the leader trial, which was done with liraglutide actually, that exerted the molecule from this particular Novo Nordisk exerted a beautiful cardiovascular outcome results along with the weight reduction, that is the liraglutide. And later on, the semaglutide exerted beautiful results. They are all once in a week subcutaneous injectable anti-hyperglycemic agents, and they have shown drastic reductions in the weight also. And of late, tirzepatide has come, that is the dual GLP1 receptor and the GIP receptor block analogs, right? That is the semaglutide and tirzepatide, they have head-to-head studies. So they are exerting the beautiful results as far as in the heart, that is the reductions in the 3-point MACE, where the atherosclerotic heart disease, ASCVD predominates, and as far as this particular weight is concerned. And the last one is the non-steroidal MRAs, that is the eplerenone and the spironolactone and the finerenone. The latest entity is finerenone, which is proving to be an excellent molecule in the management of the heart failure as well as the kidney failure. So these are all called the non-steroidal mineralocorticoid receptor antagonists. So moving on to the next slide. The interconnectivity between the cardiorenal metabolic diseases is increasingly well recognized, and the approach to treatment is becoming more holistic actually. So the before 2016, the same slide continues actually. Before 2016, the treatment mainly was focused on only the reduction of the in the cardiovascular risk factors, the reductions in the hyperglycemia, the reductions in the blood pressure, and the RAS inhibition. And after 2016, when the SGLT2 inhibitors and the GLP-1 receptor agonists demonstrated the risk reduction for cardiovascular and the renal outcomes, helping the change the paradigm of cardiorenal metabolic disease management. So there is a sudden shift in the cardiorenal metabolic the parameters and the management of these particular things had a revolutionary change after 2016, after these drugs have come into existence, the more and more usage of the SGLT2 inhibitors and the GLP-1 receptor agonists actually. So, in the recent years, numerous medical societies have shifted focus away from specific measures towards a comprehensive strategy of managing cardiovascular risk, heart failure, and CKD. You can clearly see the journal, the names of the journals. That is Diabetes Care. It's an official journal of American Diabetes Association. There are two, like diabetes purely related to research, and the diabetes care is for the clinicians and the physicians and the endocrinologists actually. And the JAC is the Journal of American College of Cardiology, the official journal of the American Heart Association and the American College of Cardiology, and the Kidney International, and the Diabetes and its Complications and Diabetes Care, the European Heart Journal, and the Circulation. See, they all have shown beyond any doubt that the 2016 ADA standards in medical care, the 2018 ADA standards of medical care, and the JAC showed the 2020 ACC expert consensus decision pathway on novel therapies of cardiovascular risk reduction in patients with type 2, and the 2022 KDIGO clinical practice guidelines for diabetes management and chronic kidney disease, and so on. You can clearly see that they simply said the SGLT2 inhibitors provide insulin-dependent glucose lowering. These agents provide the modest weight loss and blood pressure reduction also. So these are all the favorable effects of this particular the SGLT2 inhibitors, which we have memorized in the introduction itself. So then coming to this cardiovascular, renal and metabolic conditions pose a high disease burden globally. See, yeah, this is overall the prevalence of the chronic kidney disease all over the world is somewhere around 850 million people are suffering from chronic kidney disease, and the estimated global prevalence of CKD is more than 11%. CKD is asymptomatic in its early stages, which contributes to the low awareness of the disease in the people with CKD and amongst the clinicians also. And more than 530 million people with type 2 diabetes all over the world. This is the metabolic aspect, and the earlier one is the renal aspect. The prevalence of type 2 diabetes is high and rising across all regions. As the age goes up, the incidence also, the prevalence also goes up as far as these the problems are concerned. And see, more than 60 million people with heart failure, that is the cardiovascular problems, that includes even the atherosclerotic cardiovascular disease as well as the heart failure. So approximately 50% of the people diagnosed with heart failure will die within 5 years of diagnosis. You always remember that heart failure is a state of insulin resistance. Pre-diabetes is a state of insulin resistance. PCOS is a state of insulin resistance. You always remember. Type 2 diabetes is a state of absolute insulin resistance as far as our Asian continent and the Southeast Asian continent, subcontinent, that is our Indian continent, is concerned. And there is a large unmet need in heart failure with a scarcity of approved therapies in some forms of the heart failure. Heart failure again is divided into the heart failure with a preserved ejection fraction, where the normal left ventricular ejection fraction is around or more than 60%, you say the patient doesn't have any heart failure, first of all. And the ejection fraction, left ventricular ejection fraction, is in between 50 and 59. It is called the heart failure with preserved ejection fraction. When the left ventricular ejection fraction is from 40 to 49, it is called the heart failure with mildly reduced ejection fraction. All the time you have to write H capital, F capital, M small, R small, E capital, F capital. This is how you mention in your diagnosis. And anything, the left ventricular ejection fraction of around 40 or less than that is called HREF, that is heart failure with reduced ejection fraction. So, again, the cardiovascular, renal and metabolic conditions are interrelated with high disease burden resulting in cardiovascular death as top cause of death in India. So, almost 1 out of 4 deaths is because of the cardiovascular disease. And the pathetic part is the unique factors with the diabetes, type 2 diabetes in India, are it comes very early in the age group. That is, at least when compared to the Caucasians, it is 10 years earlier in Indian population. That is a curse actually. This is because of the genes transmitting the disease, and as well as the background pathology is not only the insulinopenia, more of insulin resistance at the level of liver, at the level of white adipose tissue, at the level of skeletal muscle. And you see this particular again the Indian scenario, the renal parameters, that is, you find more than 115 million people with chronic kidney disease, and cardiovascular death accounts for 1 out of every 4 deaths in Indian population. The alarming fact is that one death with cardiovascular disease occurs in US or the Western scenario. 4 deaths are happening in our Indian subcontinent. Likewise, that includes the atherosclerotic cardiovascular disease, includes both the coronary artery disease as well as the strokes. And more than 10 million people are suffering from this particular the heart failure. And when coming to the metabolic issue, earlier we used to say all the time the 77 million people, 77.1 million in India are suffering from type 2 diabetes, and that is no more existing. It is more than 101 million people in India are suffering from type 2 diabetes, and when it comes to pre-diabetes, it is even more and worse actually. More than 136 million people in India are suffering from pre-diabetes. So, pre-diabetes is also an insulin resistant condition. You need to screen the patients in the stage of pre-diabetes, so as to it is the reversible stage from normoglycemia to pre-diabetes to over-diabetes. And if you meticulously adhere to the therapeutic lifestyle changes, what I said, the 5 principles, and with metformin, you can get back to the normalcy. So, that is a preventable stage from getting on to over diabetes. This is very, very important, pre-diabetes, because the incidence of the heart disease and the kidney disease is similar to that of over to diabetes. So, we need to be very cautious about this, the pre-diabetes. And the earlier I said, the cardio-renal metabolic diseases, they always overlap. See, you can see the triangle of triad, actually, the renal, cardiovascular and the metabolic. You find the overlapping with the each other. And 60% of the people with CKD have cardiovascular disease, and 30 to 40% of the people with heart failure have the chronic kidney disease. And on the other hand, around 40% of the people with type 2 diabetes have CKD. The T2DM and the hypertension is the cause, and or hypertension is the cause of more than 80% of the end-stage kidney cases worldwide. And 16% of the people with HF have comorbid type 2 diabetes and CKD. And 33% of the people with type 2 diabetes mellitus have got cardiovascular disease. And 20 to 40% of the people with HF have the type 2 diabetes. See, all are intermingled. So one is interrelated to other, and each one overlaps with the other two problems. So now you can see the SGLT2 inhibitors have come a long way in the past decade from improving the glucose control in people with type 2 diabetes to cardiovascular and kidney benefits in patients with CKD independent of type 2 diabetes. On the right hand side, you can clearly see again the cardio-renal metabolic events getting overlapped with each other. So intermingling, you can see the renal and the cardio and the metabolic. And on the left hand side, you can see the phase 3 trials have shown the metabolic benefits in the people with type 2 diabetes, and the cardiovascular trials have shown the cardiovascular and the kidney benefits in people with type 2 diabetes and the cardiovascular disease. And the heart failure trials, I said EMPA-HF and the DAPA-HF, the cardiovascular benefits in people with the heart failure with reduced ejection fraction, that is HRF, and the HPF, that is heart failure with the preserved ejection fraction, independent of the type 2 diabetes mellitus. And the CKD trials, that is DAPA CKD and the EMPA kidney, the benefits in people with the CKD independent of type 2 diabetes mellitus. And the benefits of SGLT2 inhibitors for the people who are suffering from type 2 diabetes, it is case study and the supporting evidence. So let's take an example. Let us meet Miss A. It's a hypothecated patient suffering from type 2 diabetes. Okay, it's 52-year-old the lady diagnosed with type 2 diabetes in the last 3 months. Busy working mother who enjoys a social life, has made lifestyle changes, that is diet and exercise, but is not receiving any glucose lowering medication, and she has got hypertension and dyslipidemia as the comorbidities, and her body mass index is around 29 kilograms per meter square, that is as per the Indian the criteria, she belongs to the category of obesity, not overweight. So when compared to the other rest of the world, it is considered as overweight, not obese. So the systolic and the diastolic blood pressures are like 144 bar 95 milligrams of mercury, that is it's on the higher side. She has got hypertension as the comorbid disease, and her HbA1c is 7.8, that is the target as specified by the American Diabetes is around or less than 7%. She is like in excess by 0.8%. And screening for type 2 diabetes should be targeted towards those risk factors are after 35 years of age. The risk factors for type 2 diabetes are that starts from the dyslipidemia, the age and the tobacco usage, family history and ethnicity, obesity, cardiovascular disease, hypertension, the gestational diabetes and the pre-diabetes, and the physical inactivity, and even the presence of HIV also. Type 2 diabetes may also be diagnosed incidentally by glucose testing in seemingly low risk individuals actually. And the guidelines of the American Diabetes Association and the American Association for the Clinical Endocrinology recommend the 10-year atherosclerotic cardiovascular risk stratification in all type 2 diabetes patients. So this is the flow chart you have. You can just download from the Google, or you can have it in the any ADA recommendations like 2024 guidelines. You can get it. So the inference is our hypothetical patient may belong to a very high risk category, that is 10 to 20% of the cardiovascular risk. atherosclerotic cardiovascular risk. So, what is the next option for Miss A? Miss A and her the personal the physician discuss initiating an SGLT2 inhibitor as part of a multifactorial approach to reduce the risk and the cardiovascular and the kidney complications alongside the glycemic control. So, what five factors should inform the choice of treatment for Miss A? So, optimizing adherence to the guideline directed therapy. The shared decision making involves an open discussion with the patient, integrating medical considerations and the the patient's preferences and can improve the treatment adherence. See, I worry about ending up with the major complications if we don't manage with my type 2 diabetes mellitus. And how will treatment impact my day-to-day life? It is important that it does not affect my time with my kids actually. See, these are the concerns from Miss A. And reducing the risk of cardiorenal metabolic complications should be at the top of the patient's priority list. So, discussing the importance of an early multifactorial approach for improving long-term outcomes is key to achieve the patient buy into treatment. So, the SGLT2 inhibitors offer early metabolic benefits in the people with type 2 diabetes mellitus, like you take 25 milligram of empagliflozin, canagliflozin 100 and the DAPA 10 and the R2 5. And with regards to A1C, you can see the reductions, the weight loss, that is, you can see the weight loss in kilograms with EMPA, CANA, DAPA and R2, and the systolic blood pressure, that is lowering of systolic blood pressure, and the last one, the reductions in the diastolic blood pressures. These are all the figures. You can just go through the figures. Okay. SGLT2 inhibitor showed the cardiovascular and the kidney benefits compared with that of the placebo in people with type 2 diabetes who had cardiovascular disease plus or minus heart failure or CKD. So again, you can see on the left hand side the intermingling and the interrelationship, the overlapping of the cardiorenal metabolic disease. And on the right hand side, you can see the SGLT2 inhibitor meta-analysis, a generally consistent effect of SGLT2 inhibitors across the cardiovascular outcome trials and the kidney and the heart failure trials in patients with type 2 diabetes was seen for the hospitalization for heart failure or cardiovascular death, or the cardiovascular death or the kidney disease progression. So, this is a table which shows all the cardiovascular trial outcome trials. The empiric outcome is with empagliflozin, canvas is with canagliflozin, declared TIMI 50 is with DAPA, and what is CV with is it's etugliflozin. The patients with type 2 diabetes and atherosclerotic cardiovascular disease, the cardiovascular outcomes in atherosclerotic cardiovascular subgroups across the SGLT2 cardiovascular outcome trials. You can clearly see in the empiric outcomes that there is the 14% risk reduction in the major adverse cardiovascular events and 38% risk reduction, that is the greatest risk reduction ever never seen as far as the cardiovascular death is concerned, and all cause mortality is reduced by 32% of risk reduction, and the hospitalization for heart failure is 35%, and the chronic kidney outcomes are 46%, which is the highest one when compared to the any other cardiovascular outcome trial. This is the unique feature, the unique features of this particular the empagliflozin. And the empagliflozin was associated with a decreased risk of hospitalization for heart failure when compared with DPP4 inhibitors. See, the EMPRISE the year for the United States data. So, you can very clearly see all the middle you find a line, all which are favoring empagliflozin are onto the left, which are favoring placebo are onto the right. You don't find even a single one crossing the line going onto the right side. All are favoring empagliflozin. You can see the blue circles. And as far as the right hand side also, you can see all are favoring the empagliflozin. See, as far as the atherosclerotic cardiovascular event and the primary hospitalization for the heart failure, any hospitalization for heart failure and myocardial infarction, stroke, unstable angina, and coronary revascularization. So all these parameters, when you use empagliflozin, they are all favoring empagliflozin. So all the parameters are met. What we have mentioned, the complications of the type 2 diabetes. And the empagliflozin was associated with a decreased risk of hospitalization for heart failure when compared to GLP-1 receptor agonists. I told you, when the atherosclerotic heart disease, that is atherosclerosis, predominates, the best drug of choice is the GLP-1 receptor agonist. And when the heart failure and the hospitalization for heart failure predominates, the drug of choice is SGLT2 inhibitor. I have said it many a time. Every speaker program of mine, I'll be telling this. And a combination of two, according to the European Society of Cardiology, which said in 2019, that is the first international, the international body, the major international body, which said the SGLT2, role of SGLT2 and the role of GLP-1 analogs in the de novo type 2 diabetes patient, that is newly detected type 2 diabetes patients who are at risk of developing the atherosclerotic cardiovascular disease or the heart failure, or with an established ASCVD or heart failure. The drug of choice is the SGLT2 inhibitors or the GLP-1 receptors. If heart failure predominates, the SGLT2 inhibitors, and the atherosclerotic process is the major culprit, go for the GLP-1 receptor agonist. And if they are combined, put together both in one single patient, it has got a wonderful synergistic effect. 1 plus 1 becomes 8 or 10. So that's what the ESC said, and later on EASD joined hands with that, and they came out with a common consensus in 2019. And later on, the ADA also said the same thing in 2020. 24 also the same thing is repeated by this particular the 2022, the American College of the Cardiology, the American College of Endocrinology, the American Heart Association, and the American Association for the Clinical Endocrinologists endorsed the usage of the SGLT2 and the combination of GLP-1 receptor agonists. So, what evidence supports the protective effect of SGLT2 inhibitors if Miss A were to develop CKD or HF? See, empagliflozin reduces the risk of cardiovascular death in people with type 2 diabetes and cardiovascular disease, regardless of the baseline EGFR or prior hospitalization for heart failure. The empiric outcome, the cardiovascular death subgroup analysis. On the left hand side, you can see the empagliflozin reduces the hazard ratio of cardiovascular death by 30% in people with the baseline EGFR of around or more than 90 ml per minute per 1.73 meter square of the body surface area, which is normal, and 51% reductions in the EGFR group of 62 less than 90 ml per this thing, that is mild CKD, and 22% in people with less than 60 ml, that is moderate to severe. And coming to the right hand side, the benefits on the left hand side, you can see the benefits on the kidney. Right hand side, you can see the benefits on the heart. That is, the empagliflozin reduced the hazard ratio of cardiovascular death by 29% in people with prior hospitalization, the prior heart failure, and 40% people without prior heart failure. So these are all the greatest beneficial effects of initiating an empagliflozin in the patients who are at risk of developing this particular the cardio-renal metabolic complications, the CRM complications per se. So the National Health Policy goal to ensure 25% reductions in the premature deaths in India by 2025. That is the goal of the National Health Policy. And this bar diagram shows the cardiovascular death as percentage of overall deaths in Indian adults. That is 1990 it was 15%, whereas it rose to 28% in 2016. Very pathetic. And 10%, 10.4% of the adult Indian population, they have type 2 diabetes, according to the International Diabetes Federation, actually. That is the atlas of ninth atlas of International Diabetes Federation. Now, of late, the 10th atlas has come. And the type 2 diabetes mellitus increases the risk of premature cardiovascular deaths by 3 to 4 folds. That is called the Curses 150. And Cures 150. And empagliflozin is approved for reducing the risk of cardiovascular death in patients with type 2 diabetes and the established cardiovascular disease. And empagliflozin causes regression in the albuminuria in patients with the prior the micro or the macroalbuminuria. This is the inference taken from the empiric outcome trial. On the left hand side, you can see patients with the prior microalbuminuria regression to normoalbuminuria. The 43% increased likelihood with empagliflozin. You can clearly see the placebo with the blue line and the empagliflozin with the red line. So you got a favorable effect of microalbuminuria in the patients who have already the microalbuminuria, and they have regressed to normoalbuminuria after initiating the empagliflozin. So also the right hand side, you can see the bar diagram, the graph. The patients with the prior macroalbuminuria regression to normo or micros, because clinically we say microalbuminuria is stage 1 kidney disease, and macro is stage 2. And the 82% increased likelihood with empagliflozin, that the blue is same the placebo and the red is the empagliflozin. The macroalbuminuria has either reverted back to microalbuminuria or normoalbuminuria by 82%. See, this is a significant change which we cannot expect with. Earlier, we used to think only these ACE inhibitors or ARBs. The RAS blockade, the complete RAS blockade was only able to do this magic. So, the one take home message I would like to give is either use ACE inhibitors or ARBs. Never combine both. If you combine both, there is every chance of the patient getting into the hyperkalemia, which leads to fulminant the kidney failure, which leads to acute renal shutdown, acute kidney injury, and death. So never ever combine AC inhibitor with ARBs. Per se, remember that, okay, say barring some exceptions, type 1 diabetes topic. See, any table has got four legs. See, one table is diet, one table is exercise, and one table is oral drugs, and one pillar is the four the legs of the table are the diet, the exercise, the OADs, and the insulin, and the top of the table is very important. That is nothing but continuous medical education with regards to diabetes, hypertension, and dyslipidemia and other comorbidities. That is the long term complications, either the microvascular or the macrovascular complications. And again you can see this, it's a very busy slide showing the standards of care, how you select the molecules. To start with, once again it's a dictum that any patient type 2 diabetes you come across, start with metformin unless otherwise it is contraindicated or it is not tolerated by the patient. Then go to the SGLT2 inhibitors or the GLP1 receptors, or the both the SGLT2 and the GLP1 receptors. And if three drugs are not able to get back the blood sugar to the normalcy, add insulin, or the baseline A1C is around or more than the HbA1c is around or more than 9%, that is an indication to start with